collateral sector, everything inside this is old brain, outside is new brain. Why I'm trying to say this, a new brain stroke, because it is more evolved brain, it handles stroke more easily. So IV thrombolysis, medical management, that would work better for this subset of patient. While if you have a stroke inside here, in the old brain, with perforators and choroidals involved, it's difficult. You need a more robust device to, treat these patients. So I have already shared this stats with you. This is how, every minute 1.9 million neurons dies, and in a 1 year you lose a brain which you made in 3.6 years. Well, stroke, we all know risk factor, probably same as like coronary artery disease. Some of them can be easily controlled, some of them are difficult, some are non-modifiable. And this is one thing, Vidra, which I will be talking, which we proposed as a risk factor for stroke. So this is a case example citing the importance of stroke treatment. This is minute 1. A young boy had a stroke in a village, goes for district hospital, get a CT scan, and this is the usual scenario. 90% of patients you and me treat. The very next day you get a CT report, he's referred to medical college or a tertiary healthcare centers on the second day, and he is already past 24 hours by that time. He is prescribed with an aspirin and physiotherapy. He goes back, he remains lifelong crippled. Father is a shopkeeper, he leaves his job, he takes care of son, and whole family is ruined. So these are the real lives behind this problem. Well, when I came to Udaipur, I realized that like stroke, the problem was, as I said, please don't go on my slides. I'll just try to give you the message which I want to convey today. I had a problem. I had infrastructure. I started first angiography intervention in Rajasthan. I mean, obviously Kaushik sir was my first teacher when it comes to intervention. At cath lab exposure I got from him. But I had infrastructure at that time. Thrombectomy, IV thrombolysis, stroke unit, everything was there 18 years back when I came here. So the problem was, I'm doing thrombectomy, but results were not that good. Because in a first CT scan, you don't see the amount of damage one has incurred. If somebody has lost whole hemisphere, then there is no point in opening up the vessel. So this is the project we started doing with DST, that can we have a biomarker, a blood simple biomarker, where we can actually prognosticate the stroke and optimize the treatment time. So basically, cell-free plasma DNA is a pretty simple, it's 300 rupees test, which we started doing as a part of DST project. So basically, it's very simple. DNA is inside neurons. Once there is stroke, neurons break down. There is release of DNA in the blood-brain barrier is breached. It comes into circulation. So depending upon amount, if it is less than 2000, you have probably very less neuronal brunt. If it is 2000 to 5000, it is moderate kind of insult. If it is 5 to 10,000, it is some kind of severe insult. If it is more than 10,000, whatever you do, patient is not going to make. So don't waste your resources, IV thrombolysis or mechanical thrombectomy and all those things in this subset of patients. Rather than treat them medically, if need be, decompress them. So this was the importance of, because you don't require diagnostic biomarker, you require biomarker for prognosis and treatment optimization. Because the problem here was, if a patient coming for thrombectomy will ask me, okay, मैं 2.5-3 लाख रुपए तो खर्च कर दूंगा, पर गारंटी क्या है कि पेशेंट ठीक हो जाएगा? And I really had no answer based on a plain CT scan. So this is how it works, and this is a PCR machine. So we do as a part of PhD project, and this is state government has applied patent for this. So this is how it looks like. Cell-free plasma DNA. We have published this. Okay, fine. So let's come to next part. You have a biomarker. Now you need to image each patient. So depending upon what place you are working, you will do a CT scan, CT angio, MR angio, a Doppler, PCT, what you are comfortable and your institute is best at. So here, and we can do now we have in cath lab CT, expert CT along with a DSA. So that's another thing one can do. Well, the whole thing is, because whole world does CT angio based protocol. Wherever you go for a talk or in conference, you will find CT angio, CT perfusion, TTP, MTT, all these difficult words. Even radiologists would not know them. Forget about clinicians. So the very simple thing is, you make an MR-based protocol which we developed few years back. It's a 13-minute MR-based protocol where you do a diffusion-related image, you do a FLAIR image, and you do a MR angio. That's all. my idea, so CT versus MR based protocol that we did in sizable number of patients, we published this also. It works better for our patients because they are paying from their own pocket. Unlike in Western countries, all the literature comes from there, and they have, like all are insured or covered, so it doesn't really matter to them. So this works. Why it works better? Why it is safer for us? Because DW image will tell you how much brain is already gone. So if it is 1/3, 2/3, you do your best efforts. If it is whole thing is gone on DW, within few minutes you will find in DW whole brain is white. It's gone. There is no need to open vessel, even by IV thrombolysis. So MR, a CT angio will also take like 9 to 10 minutes. But MR based protocol takes 30 minutes. It works very well with our patient, and we have enough data for this. Well, then I come. This is a tight stenosis in a carotid artery attributed to stroke. Obviously, if it is tight, 99% blockage, you put a stent, open the vessel, job is done. But many people with 90% blockage live whole life. Kaushik sir would know that. So what? And many people, this was the time in 2006 when I was very happy we published the largest series on carotid stenting in the country. And then same year in NEJM there was article carotid artery stenting case open or closed. So it was like gone in 2006, and I joined as AP in Nimans at that time, and I was very excited that we will do. So these things do change with time. Nowadays it's standard of care. No one talks about doing a surgery in a carotid stenosis patient now. So this is how the time changes. This was the past. This is present. Putting a stent, and future will belong probably to pills and vaccines. Well, so what I am trying to convey, the traditional luminal imaging by Doppler, MR angio, CT angio, whatever you do, because you do some kind of brain imaging and angio in all stroke patients, okay? So it will demonstrate disease only when lumen is stenosed. It will not differentiate between cause of stenosis, radiation induced, atherosclerotic, or something else. It doesn't provide about activity of the plaque. Well, so these are the patients because what I'm trying to tell you, plaque imaging. We all know vulnerable plaque and stable plaques. So how do you pick them up? Because even that, again, I'll show you, we published stenosis of 20 to 50% in a carotid artery can lead to stroke compared to a 90% stenosis, which will, lifelong patient will live with it, with good medical treatment. So it is important. So nowadays you have plaque imaging. It's very simple. So it is because carotid arteries are anyway very superficial arteries. It is away from lung and heart, so motion artifacts are not there. Only thing is, it is labor intensive. It requires surface coil. So plaque imaging, the whole idea is we all know what is vulnerable plaque. Breast fibrous cap, lot of lipids, ulcerations, inflammation inside the plaque, a mobile plaque. So everything can be picked up on MR. So you do a plaque imaging and you can actually pick up that these are the subset of patients because mild stenosis. We were not treating blister aneurysms. I cannot see. Actually, this is a subarachnoid hemorrhage patient, and the cause of subarachnoid hemorrhage is there is a small blister here. Nowadays, earlier 5 years back, these blisters were not treated. Because छोटा सा 1 millimeter का है, there was no treatment. You cannot clip it. You cannot put coils inside. Nowadays, you have better, modalities. You can put a fluid diluter and it gets occluded. So what I am trying to tell you, mild stenosis is also a volcano to be ruptured. I mean, you have to really pick it up early on so that you can. And most important thing here is, apart from characteristic I talked about, intra-plaque hemorrhage. That is the most common determinant that this plaque is going to rupture or going to remain stable. Well, so intra-plaque hemorrhage you can pick up with this. So this MR angio is absolutely normal. Normal carotid arteries. On traditional MR imaging, this is a normal looking MR angio, but you have an intra-plaque hemorrhage there. This is intra-plaque hemorrhage. So this is a mild 10-20% stenosis, but you have intra-plaque hemorrhage here. So this is a vulnerable plaque. So this was published. These were patients with mild 20 to 50% stenosis, and this we published in leading stroke journal in the world. Stroke day. So now probably the practice is going to change. As of now, I'm not going to deviate you. As of now, 70% stenosis is indication for doing it. carotid stenting or surgery. But probably I feel that because in my practice I found that probably degree of stenosis doesn't really correlate. So that was the whole idea, and we took, we have two carotids. So control was contralateral carotid. We took patient with bilateral carotid stenosis. So there was control also along with test. So this came well. MRI and histopathology finding correlates very well. So idea is, and what I'm trying to tell you, MR plaque imaging. This is doable. In most of the MRI today we have, this is doable. Only thing is you need to really talk. So this is how I just skip. Then comes, we are dealing with heart attack or brain stroke. It is all atherosclerotic disease. Do we have something to vaccine against? Well, this is science, this is not fiction. There have been some studies where they have injected against CD99, and these are controls, and you have vaccinated mice where they have less atherosclerosis. You have better drugs also, because medical treatment is also immensely changing. As I told in the beginning of lecture, probably future belongs to pills and vaccines, not with stent also. This is obviously, this is radiation-induced plaque where we did a conjoint stenting. So this is not atherosclerotic. So let's come to another debate. You have many people who do not have any risk factor, hypertension, diabetes, hypercholesterolemia, sedentary, they're gymming every day. One of my senior neurologists, he was a very fit person, no obesity, nothing. He actually had a heart attack on treadmill itself. And you know, many times we hear, no risk factor, regularly exercising, still you have events. So is there anything other than standard risk factor we had? When we started doing mechanical thrombectomy, we were collecting all these thrombus samples. We subjected these thrombus samples to new generation sequencing. That's metagenomic analysis. That is, you can pick up even if there is single bacterial DNA, you can pick it up. In culture, you will not find anything. It's 2% positive rate with a standard culture, we do blood culture, urine culture. But any given sample, you do new generation sequencing, you pick up every single bacterial DNA. So in first 4 samples, because again we applied to ICMR for the client, the first 4 samples we could isolate 27 bacteria. It's a sterile compartment, carotid. So these were the patients who had carotid plaque, they had artery-to-artery emboli, they had stroke, we retrieved the thrombus, we subjected them to NGS. So this was phylogenetic, presence of these bacteria. I tell you, this was very interesting. So these are not pathogenic. You say this is a bacteria sitting in the carotid plaque. Why not there is septicemia? They are commensals, they are low-grade virulents. So they sit inside, they are basically in and around a skin or oral cavity, and somehow they get transgrade to blood to sit in carotid plaque. And they are there for months and years altogether. Now we can pick up, now we have to hypothesize, is there any association, causation, or what is there? So they sit there. So what I could think of, frankly speaking, this was a finding which we really do not know answer, but my understanding of this probably, after a literature search, lactobacillus was there, which is a good bacteria. But lactobacillus produces acidic milieu in plaque environment. So LDL cholesterol oxidation is 100 times faster. So more active LDL cholesterol, bigger buildup of plaque. So that is how probably it can do. I have nothing to. Then you have biofilm. Certain bacteria forms a mucilage covering over the plaque. So you have a biofilm dispersion. Let's say somebody has a great stress, physical or mental. There is surge of norepinephrine. Iron, copper, these are in bound form. So they are released into blood circulation. And because of that, there is a biofilm dispersion. So these bacteria get exposed. And what do? They produce local inflammatory environment. They are commensals, like Staphylococcus hominis, which is not pathogenic. But they produce local inflammation. So what happens? Inflammation, some rupture there. So there is intraplaque hemorrhage. Many times, किसी को बहुत जोर से stress और heart attack आ गया. Probably I'm just trying to put analogy to stroke to this. So this is how it is, and some of them are known like Pseudomonas fluorescens, which we identified Enterococcus. They are known to elevate factor 8. So again, these are thrombogenic. So these are my own, interpretation and suggestion probably. Again, there are some indirect mechanisms also. This is what we published in one of the leading journal. Okay, so coming back to a very basic thing for residents, every time I'm asked, how do you manage blood pressure in acute stroke. So acute stroke management, let's be very simple. If it is intracerebral hemorrhage, because mostly I just touch intracerebral hemorrhage also. If it is intracerebral hemorrhage, first 6 hours reduce them below 140/90 because you want to avoid hematoma expansion. But if it is more than 6 hours, you gradually reduce them 15%. If it is ischemic stroke, then you are more liberal. If you are doing IV thrombolysis or mechanical thrombectomy, then reduce them to 180/105, below 180/105, and keep it like this for at least 2 hours after doing the procedure also. Because otherwise there is reperfusion injury, this is hemorrhagic transformation. If you are not doing that, unless until there is congestive heart failure or aortic dissection or some other problem, you don't reduce them unless until it is above 220 systolic. So you don't reduce, if it is less than 220, you just gradually reduce them, don't do drastically. So ischemic stroke, more liberal. Hemorrhagic stroke, yes, you have to be more stricter. So this is how, this is the experience. Like now, to the left ICF was occluded, there is a small infarct, and it is well compensated from the right internal carotid artery. So whole circular village is complete. So I thought there is no need for doing anything, and few days later patients end up with a large infarct here. So what I am trying to take all these collaterals, if you have a blocked artery, you don't know when you are going to have loose motion or typhoid, and your pressure drops down, your compensation will be lost. So if you are in window period, better to open artery despite of seeing collaterals. That I learned. And nowadays it is dictum that you open irrespective of whether collaterals are there or not there. Well, initially we published that, but now I have taken it back. This is not the case. Few other things, newer things, probably this is this year's update on stroke. Tirofiban nowadays, if its patient is not eligible for IV thrombolysis or mechanical thrombectomy, you can use tirofiban for first 72 hours, but still not established. Then nowadays this big trial has shown that if you compare mechanical thrombectomy and medical therapy alone, what I am trying to take, because we do IV thrombolysis usually. The patient is within first 4.5 hours you do IV thrombolysis, and up till 24 hours you do mechanical thrombectomy. But nowadays things that you don't need to IV thrombolysis. If thrombectomy is available, then you can straight away take the patient for thrombectomy. Because why do you put a drug which can produce hemorrhage? This is another trial, very simple thing, dual antiplatelet, single, if this is small infarct, lacunar infarct. Nowadays the practice is to give dual antiplatelet for 3 months followed by single monotherapy for rest of the life. Statin 80 mg in the beginning, again for 3 weeks, then you can shift to 40 mg atorvastatin. Retiplase, nowadays it is cheaper drug because we had tenecteplase and alteplase, these two things for IV thrombolysis. Okay. So, like 50 mg TPA you are giving, or tenecteplase like 20 mg or 25 mg. So, retiplase is a cheaper thing, and there is quite. So, this trial probably showed it can be used in Asian population. Well, this was interesting, AI. So, this was a recent article published that AI-based judgment on stroke actually produces lesser vascular events. That myocardial infarction, if you make decision based on AI, myocardial infarction will be less, strokes will be less. So this was only thing, but outcomes were not different. But I believe that physical presence or examination will not substitute for AI in times to come also. This is again a trial. This is a very simple thing. You are doing a mechanical thrombectomy, please keep patient's head flat. Because many times in stroke patient you keep 30-degree elevation for head for reducing ICP, but you have to keep that based on this recent trial, 0 degree. If you have dissection, usually it is antiplatelets only, not anticoagulation. That we were doing in past. Everybody we were putting on heparin and oral anticoagulation, but nowadays it is said unless until this occlusive dissection, the vertebral artery is occluded, then you give anticoagulation for initial period. Otherwise, you give them antiplatelet. Pediatric stroke, large vessel occlusion, it is same. 2 year to 18 year of age is again mechanical thrombectomy is better than doing medical management only. So as I said, so you have many challenges as over last 2 decades here also. it is more or less same everywhere in the country. Awareness problems, access problem, action problem, medical problems, technical, financial issues, and top of that we have religious problems also. So you create awareness like this stroke ambulance, trip, ship and ship back. Many times now it is working actually. I talk to my friends in Chittor also, Bhilwara also. They would put IV thrombolysis is done in Chittor, Bhilwara, Dungarpur, and they will put drip. They will ship the patient. If I don't need to make a thrombectomy, in 2 days time I'll send them back. If there is thrombectomy, they will be with me. So this is how it is. Comprehensive stroke center, it is not everywhere in the state, but comprehensive stroke center is by because you have everything neurosurgical expertise, neuro ICU, cath lab, preferably a biplane cath lab gives you better success rate. And if I don't have money, the money I put it on stroke unit, which is cheap, but it is probably most effective out of 3 options I suggested. So we made our own system. NNT will, as a physician, will always ask what is NNT for mechanical thrombectomy. It is 4. So this is how we work. Acute stroke, we work in a group, so everybody was on the same page, whether it's cath lab technician, radiologist, neurologist, neurosurgeon, emergency neurologist. So how this is we work. Real-time check is there. So actually you can accordingly watch your time. Door to needle time is 40 minutes. It's 30 to 40 minutes is the ideal time for doing an IV thrombolysis, and by the time patient goes to cath lab directly. So we have this, everybody now CT and MR, 99% time I do MR based protocol because I told you the reason for safety, and my results have improved, not because of I have become better, but probably this MR gives me more safety margin. So only in pacemaker or very rarely in 1% patient motion artifact pacemaker, because everybody is here, MR कैसे होगा, आधा घंटा कैसे लेटेगा patient, it's acute emergency है. This is not the case. Now we have enough number to show that. Just wanted to start. So take I have some 10 minutes, sir. Anyway, this is that I just wanted to show how mechanical thrombectomy is being done. It's a very simple thing. Maybe I'll show you this picture. Once the patient reaches to cath lab, you have a large vessel occlusion. You have middle cerebral arteries occluded, posterior cerebral arteries occluded, basilar arteries occluded. These are large vessels. So once large vessel is occluded, it's a now you can see it very well. This is carotid tight stenosis and MC is occluded here. Okay, you first, because you need to have access, you open carotid first and go up. So with this, you can see balloon, you open the carotid first, you go up, and then you open this with a stent retrieval device. It's a kind of stent, you put it, angle the thrombus, keep it there for a couple of minutes, and pull it back. So it is not like primary angioplasty that you leave the stent, you take the stent away after doing the procedure. Because brain, you need to have, brain have hemorrhage unlike heart, so that's a tricky, different game. So these thrombus sample, as I spoke, we were doing mechanical this NGS. This is basilar artery. This is I think yesterday's case only. The vertebral, other side vertebral is not there. This vertebral artery is occluded. Basilar artery occlusion, I tell you, 80% mortality. They don't really survive. So within first 24 hours is window for anterior circulation. But in basilar artery, if I have brain stem spared, I will do opening of the vessel for 72 hours also, because you have preserved brain stem so far, you salvage it. So this is how you go up. In this case, nowadays we do sometimes aspiration along with thrombectomy. So that is called Solumbra technique. So you have to go reach out to temples also. I was lucky, I could get in many temples this access, and I treated many of the priests and administrators, and that is I could build a rapport in Avri Mata Mandir, where I did a camp right in the Garbhagriha. Because that's a fantastic example of physiotherapy. Avri Mata, if some of you have visited, they have made some of their patients goes sitting, crawling, and like fantastic physiotherapy so many years back, which still we have no answer. Well, so I come brain hemorrhage. So I talk, so in nutshell, ischemic hemorrhage, you identify Residents fast, you should remember, facial weakness, arm or leg weakness, speech change, 90% stroke to pick up with fast and time to intervention, timely intervention. So, 4.5 hours, IV thrombolysis, 24 hours, mechanical thrombectomy, and stroke unit, three things. You should remember, rest all, even if you forget. Well, I come to brain hemorrhage, which is a very common thing. We all see hypertensive brain hemorrhage in glutamen or basal ganglia or thalamus. We treat them medically, fine, perfect. We have been doing it from years altogether. Because this is something, brain hemorrhage is also a dynamic event. Why it is dynamic? It is not that BP has rose up, there is burst of vessel, there is hemorrhage in the brain. First, there is hematoma. After 24 hours, what happens? The RBCs break down. So there was primary injuries through hematoma. After 24 hours, it is RBC breakdown, hemoglobin products, free radicals, inflammatory markers, macrophages, and there is secondary brain injury after that. So you lose more of neurons. So if you can do something before 24 hours, again this is an experimental stage. We did few patients, we asked for a grant for this project also. My idea was, if you can, without doing a surgery, if you can take out 70% of hematoma through a catheter, the catheter which we are pushing into the groin, if you can directly put it somewhere here, I'll show you that also. So if you can remove the 70% of hematoma, you can modify the pathophysiology of the disease, because the edema and everything will come second, third day later on. So if you have a 60%, the reason for doing this is the data. If you have 60 ml with lower than 8 GCS, they have mortality greater than 90%. So you cannot do later on mannitol and all these things will not work. So you have it. If it is acute hematoma more than 150 ml, patient is not going to survive for sure with any kind of medical management. Well, इसको भी चला नहीं सकते. So basically, because in FNB program, I have neurosurgeon, neurologist and neurologist working with me as fellows. So one of my fellows, who is a neurosurgeon, he started doing a simple drilling from here, reaching to the hematoma here, because it's through a catheter made in our own lab. It's a sheath, sir. It's a sheath which has been, put side holes, because now we will probably get a dedicated device, but sheath with a side hole, you go inside. And now cath lab is so advanced. Why I was doing biplane cath lab? Because in cath lab we have a CT scan, you can do fluoroscopic guidance. With under fluoroscopic guidance, you can take your sheath or catheter in. With a CT, you can be sure of position. The catheter should sit in the middle of the hematoma. You suck it out, whatever amount you can, you just suck it out, and then you do TPA. Okay? कोई बात नहीं, it's okay. वीडियो सर नहीं चल रहा है. हाँ, वो चलिए. Anyways, अभी let's not break the rhythm. So you take, and then what we do is, you put 1 milligram TPA, lyse it, do it every 12 hourly for 3 days, and take as much blood out as possible. So for 72 hours, your sheath remains. I tell you, it is because surgeon put EVD day in day out. EVD is a bulky thing. With metallic stellate and everything. So so first of all, we had to establish safety of this device. So now, since we have this patient and we have published this, we have safety of the device. So you see, the after aspiration, you see the amount of blood going down. In 72 hours, blood is going down. So here you can modify, because on the day one, your hematoma will not look that nasty, but on the fourth day, it will become nasty, and then you will not be in a position to do anything about that patient. So you modify it before secondary brain injury happens. So based on pathophysiology, so this is window period for hypertensive basal ganglionopathy, probably. Well, this is something called, for all students, this is typical starry appearance. This is subarachnoid hemorrhage. So blood is not in brain parenchyma, but in the CSF spaces in the cistern here. All white is blood. So the patient had aneurysms, coiled, and a vascular coiling. So that's an answer. Again, cost was always a hindrance. So we developed this double microcatheter technique for broad neck aneurysms, which was probably more economic. So nowadays, earlier we had no treatment for giant aneurysms like this, big aneurysms, no treatment. So now we have this is something called flow diverter. You put a stent-like device across the neck of the giant aneurysm, and over a period of 4 to 8 weeks, it's thrombosed. Well, and this is very relevant practical problem that we as a physician, Um, Whatever you do in stroke, unfortunately, your 40% patient will have some residual deficit, be it cognitive, be it motor, be it vocational, occupational, or speech. So what do you do? So you, even all of us as a neurologist or physician, we just refer them to physiotherapists. That's what we do. Because rehabilitation is such a specialized branch, neurorehabilitation. You need to have a physiotherapist, occupational therapist. Physiotherapy does motor things. Occupation, somebody has a strength to put up a comb, but he doesn't know how to comb it. That's the job of occupational therapist. Speech therapist. Then for cognition, for memory, for depression. If somebody is depressed, he will not do any kind of therapy. So there will be no outcome. So cognitive therapy. So four people put together, they make a neuro rehab specialist. We don't have any. We don't have any anywhere. So this is irony, and you know the idea of physiotherapy is जो सबसे ज़्यादा घर के पास है जो सबसे सस्ता physiotherapy का, and that's the reason for poor outcome in most of our stroke survivors. So I realized this. So we started doing this online physiotherapy with a team of 4, and then we had to develop a fellowship program also for physiotherapists for this neuro rehab fellowship. So all this, you just charge them 100 rupees for 1 hour and people are happy. And you can do online with a smartphone. You can do this physiotherapy in a distant remote village. There is no physiotherapist. So this worked well. So this is the study we did. Because in physiotherapy, intensity matters, repetition matters. It has to be 7 to 8 hours on physiotherapy. So this all does matter. It is not, but this is a famous quote, neurons that fire together wire together. So you have to repeatedly stimulate the healthy surviving neurons so as to have better results. For speech therapy also, this is eyelid therapy, which is again 8 hours therapy in a day. Who does it? That's why we don't get outcome. Speech रही जाती है उसकी, but how important a speech is for a, how important memory is for a stroke survivor, but that is completely neglected. Well, so yeah, various form of therapies. In VR therapy, somebody is zero power, but you teach him how to cut a vegetable. So you have to, this VR therapy is there. So we have everything. We just need to look at all these things. VR therapy, you produce a 3D VR therapy, patient can do everything with a zero power. This is a small, I developed this whole comprehensive neuro rehab unit in an area of 1800 square feet. So that's 4 specialties put together. Everything is there, including robotics also, I'll show you. So this is, then you have vertigo and all these, vertigo lab and dedicated therapy for this. He's telling you. So this is a kind of exoskeleton for patient zero power in limbs. You put them in an exoskeleton, there is a FES, functional electrical stimulation channel stimulating muscles, and people start walking either on treadmill or on a ground. So you do this repeatedly with a zero power patient. They do become ambulatory over a period of months. They may not be having normal power, but the improvement is immense. So comprehensive neuro robotics, this we do not have, but we have very cheaper Indian versions also. Many people are doing work on this. I'll just finish it shortly. This is again this is an Indian device for hand spasticity. We have all these tools. These are cheap tools. And this is the last thing which is very close to my heart, neurotheology. Because unless until brain and spiritualism, these are all linked together. And there has to be some way that you can do better with this theology also to any kind of neurological problem, be it stroke or Alzheimer or whatever. Thank you very much.
We are open to the question and answers for this session.
Congratulations for the nice talk and the new things which you have come. And I think so R&D 2 is proud of you.
Thank you very much, sir. You tried up. Sir was, I just forgot, sorry, I forgot your name, but because it was for us medicine, super specialty postings were very less. And sir was one person who was very meticulous, and I learned from him. Let me tell you how sir was head of the department also and tail of the department also at that time. Now, but everything you can do on your own. So single person can run a department, build a department, and that's what I could do.
You said one thing in initial, that cfDNA was one which you made a marker, estimating that thing. You said what related to the prognosis of that patient on the level basis. And is it that only related to neurological stroke or to other stroke? Have you ever any opinion related to
Yes,
that.
sir. Yes, I get your point. Actually, this is not specific. I mean, this DNA is in all cells, whether it's neuron or any, even trauma, it will increase. If you have muscle injury, muscles also have, I mean, it is non-specific. But you just, at that point of time, you know clinically it is stroke, there is no other trauma, sepsis, head injury, then that becomes relevant. So it is non-specific but very sensitive. So it applies to everyone. I mean, it applies for kidney injuries also probably.
Yeah, just I want with the related to the cardiac issue.
Yes.
Right. So you have anything of estimating this thing? I mean, a sudden stroke or blockage.
Yes, but cardiac they have already better markers. So I think they have better specific and sensitive markers, but there is nothing in stroke.
They are there. Has been added. Can you are there any want to extend this your experience in other
Can
things?
this biomarker be correlated to a cardiac
Cardiac.
Yes.
That's one thing which you keep is a new thing. Why not
Because
just
this is-
pass out to the other branches?
Yes, true. Because most of the time I feel that most of neurointervention is, I mean, to be very honest, brain and heart are different organs with different philosophy. But when it comes to intervention, actually neurology is following cardiology. Because today we are not talking about primary angioplasty. But sir, I tell you, I mean, I have not done any study. But mechanical thrombectomy, you are leaving some residual stenosis behind. Why not to put a stent? But that stent device should be good enough. So maybe as of now we do not have that good device like what we do in character. I mean, in coronaries. Yes, it can be extended. Yes.
Second one is related to the hemorrhage what we said. That nowadays, if you have an hemorrhage there in the basilar artery, seeing that first 4 hours and then the secondary things happening with the collection of the blood. So is as a part that now we should drain out those things, those blood collected blood, before that it causes a shift to the midline shift and causing more damage.
No sir. I cannot recommend that because sir, again, this is my project actually. So because as of now, standard of care is for hypertensive bleed is medical management, and if you have significant mass effect, because these are deep-seated bleeds, so the standard of management today, surgeon would just remove the bone flap, so he will decompress. Because going inside the brain with surgical things would produce more damage. So it is not recommended to a cranial surgery. But what he will do is he will remove the bone flap so that pressure can be accommodated. So this is the standard care. What I was discussing is only part of research protocol. So maybe in times to come, things have been changing. So like that.
Some 50 years ago, I was sitting here. Some 50 years ago, I was sitting here. And for a short while, I spent some time there. Today, I realize that sitting here would be most welcome again with your lecture.
Thank you, sir.
One thing was, yes, I was wondering, in a patient where a block of the carotid has been suspected,
Mike, pass me again, sir.
in a patient who has no comorbid factors, and there has been an accidental discovery of a carotid block, which is significant according to your standards, what is all right? What would be the criteria to find out the status of the plaque? Would intravascular ultrasound be one factor? That was my one question. Second question is Sanjay Gandhi being so busy nowadays, putting on valves after valves, and people getting older, getting their aortic valves sclerosed and stenosed, most of them requiring new aortic valves. But most of them do not take the regular anticoagulants, and they are subjected to thromboembolic phenomena. What preventive measures would you advise in such patients apart from a regular anticoagulant, which I afford to miss? Third question was, when I was a resident some 50 years ago, my teacher, Dr. Shurveer Singh, and may God bless his soul, used to examine the teeth of every patient of myocardial infarction. Every patient of myocardial infarction, he should examine the teeth. And he used to watch for their dental hygiene. And if the patient's dental hygiene was bad, the kick would come to me. He would virtually physically handle me. So why his teeth are dirty? And in the hospital at that time, there was a regular supply of Dant Manjan to every patient to clean his teeth. So much so that Dr. Pooja would recollect, Dr. Jain Saab would recollect, that we had published a paper about the role of chlamydia and other gram-negative microorganisms in the pathogenesis of cardiovascular and cerebrovascular stroke. So that's why you've done a great job by describing the role of bacteria in the genesis of stroke in an unsuspecting individual. And to talk of theology and the abstract without doing the practical, that is anybody's job. But here is a man who talks of theology, who talks of the abstract after doing such a practical things, and who has brought in a paradigm shift in the management of neurological disorders in this country. My heartiest congratulations, and I think it requires a big applause. Now you can answer me.
Yes, sir. Sir, I mean, starting with the last question first. Sir, very rightly. So that's what I was thinking. Vidra. Vidra is a Sanskrit term. Vidra means spotless, cleanliness, hygiene. So that, as you are saying, these are the bacteria or commensal from oral cavity, from the skin, from gut. So these are all bacteria which we should identify. So they have a role to play. They sit there, they are innocent bystander. No, I mean, once they become symptomatic, they make plaque vulnerable. We know reasons, and we have hypothesis to prove that they make plaque vulnerable. So yes, Vidra is in addition to standard risk factor we have, or lack of hygiene, we can say. Second thing is IVUS, as it is being used in cardiology practice already. IVUS I have not done in my patients, but MR plaque imaging is easier to me because I have a stroke protocol based on MR. So everything is MR. Because what has happened in neurology, everything has been made complicated. I mean, right from using discipline or not using discipline also to 30 years. I mean, unfortunately. So neurology probably was a passive medicine to start with. So these kind of things, you have MR-based protocol and actually perfusion, CT perfusion, MR perfusion. So machines are being sold by industry, and they would have, now this rapid software is there, which is like 70 lakh rupees for rapid software, which will tell you that whether you need to do mechanical thrombectomy or ideal thrombolysis in this patient or not. And in Narayana and many of the corporate hospitals, they have rapid. So it will do perfusion imaging. So whole idea of perfusion is very interesting, fascinating, because you see penumbra, the salvageable tissue. But I ask, why do you need to see penumbra? You have an infarct, you have a 1/3 MC-tertiary infarct, you open the vessel. Whether penumbra is today there or not, tomorrow it may be there. So how can you be so sure that MC occlusion with collaterals, patient is going to be fine all the life? Open it up, because you have very little risk at that time. So this was the idea of doing plaque imaging in MR based, because it picks up very easily intraplaque hemorrhage, ulceration in the fibrous cap, lipid, if it is predominantly lipid component. If it is more of fibrous component, well-defined fibrous cap, then it's a stable plaque. Coming to your first question, stable plaque. As you said, no stroke, nothing. It is incidental finding. Well, if it is incidental, most probably it is going to be a stable plaque where you don't have to do anything. Just follow them up and give a aspirin. That's all you will do. But if it is a vulnerable plaque, and maybe because कई बार patient miss करते हैं TIA को, they don't really consider very seriously. Sometimes visual loss or some weakness for 2 seconds, they miss it. So patient was symptomatic, you take a history, go back, and it is a vulnerable plaque. So I would say here, sir, with modern medicine, with the best of the statin, dual antiplatelets, ACE inhibitors, it takes 6 to 12 months for stabilizing a vulnerable plaque. 6 to 12 months. Putting a stent is like putting a gauze on the wound. It endothelizes within 1 month. Am I right, sir? Put a stent across, if it is a bile stenosis or 50% stenosis, ulcerated plaque, put a closed cell stent across it gently, don't do any angioplasty or balloon dilatation even. It will endothelize and make the plaque stabilization faster. So that's how I would take it.
Mechanical C for aortic stenosis.
Aortic stenosis, yes, because yes, anticoagulation one has to, because cardiovascular stenosis is 30% of stroke chance. And this is the only indication where you use anticoagulation or heparin. Unlike others. In these patients, I would always say, any kind of cardiac patient, a previous history of cardiac, you do a halter. Preferably nowadays, I do at least 3 days minimum I do halter. But 7 days, because sir, would intermittent AF or paroxysmal AF is picked up only in 25% cases, even after doing 7 days of halter. So they may have AF picked up maybe a few years later when he had another stroke. So doing a dedicated halter, because rest other things have been already done. A prolonged halter monitoring for any cardiac patient. So that's what you treat AF also.
Thank you, Atulabh. I would like to compliment and compliment Dr. Atulabh for such a wonderful talk, and really we are proud of him. I think with guide, I feel elated, I feel energetic when I see my postgraduates excelling in their field. There is energy there. Atulabh is here. Dr. Vikas Khandelia, another unique India. He is working with Dr. Head in Kota Medical College. And the Kota Medical College, every month, 2 days of and really proud of giving me all. He lately we have not and we are and established the whole department.
But ladies and gentlemen, what should Dr. Baum do to look more elder? When you say you'll be teaching Dr. Atulabh, who himself is 15, what should you do to look more elder?
It is energy they provide. When I see that doing such an excellent work, the original work, and excelling their field. It's an energy is all of us. Because only two things they make the parents, if their child excels, and the students, if he excels in the field, then we consider
Thank you, sir. Thank you, sir, for this informative session, and also to start with a little humor.
We would now like to call